Welcome in,
So-
Taylor. Did you swear on the recording?
For the, not quite.
Oh.
For the,
Probably.
so we'll go over the cardiac arrest. We'll watch this video. We'll kind of go just down the algorithm again. We'll talk a little bit about that and kind of how it applies in the mega code, and then we'll just do a couple of the practice scenarios that go along with this algorithm. So we'll turn this one on and get started, and then we'll bring the
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer. The cardiac arrest algorithm is the most important algorithm to know for adult resuscitation. This algorithm outlines the steps for pulseless patients who don't initially respond to BLS interventions, including a first shock from an AED or manual defibrillator. Because many patients with sudden cardiac arrest demonstrate VF at some point in their arrest, it's likely that ACLS providers will frequently follow the left side of the cardiac arrest algorithm, which we'll do here. After assessing the patient, the first and most crucial step is minimally interrupted high-quality CPR. The AHA recommends the use of audio and visual feedback devices to ensure that CPR quality is maintained and optimized during a resuscitation attempt.
You didn't have any extra
Treatment
of those
then
cards,
branches
did you?
into two pathways,
I don't have one.
one for shockable rhythms,
two.
which include VF and pulseless VT, and a pathway for non-shockable rhythms, asystole or PEA. For shockable rhythms, the first step is to deliver a shock as soon as a defibrillator becomes available. The appropriate energy dose is determined by the type of defibrillator, biphasic or monophasic, and the manufacturer's recommendations. After the shock, immediately resume CPR, beginning with chest compressions. If there are available rescuers, IV or IO access should be established. After 2 minutes, conduct a rhythm check. For persistent VF or pulseless VT, give another shock and resume CPR immediately. When IV or IO access is available, give 1 milligram of epinephrine during CPR after the second shock has been delivered. Repeat epinephrine administration every 3 to 5 minutes, or every 4 minutes as a mid-range, which corresponds to every other rhythm check. During resuscitation, epinephrine acts as a vasoconstrictor, which increases cerebral and coronary blood flow. Epinephrine does this by increasing mean arterial pressure and aortic diastolic pressure, which improves perfusion pressure to the brain and heart. After 2 minutes of CPR, conduct a rhythm check, being careful to minimize interruptions in chest compressions. If a rhythm check reveals a shockable rhythm, deliver another shock. Resume CPR, beginning with chest compressions, for 2 minutes immediately after the shock. At this point, you may consider giving amiodarone or lidocaine, antiarrhythmic agents that have been clinically demonstrated to improve the rate of ROSC and hospital admission in adults with refractory VF or pulseless VT. Amiodarone is a complex drug that affects sodium, potassium, and calcium channels. It has alpha adrenergic and beta adrenergic blocking properties, and it also blocks the action of hormones that speed up the heart rate. The overall effect is to slow the heart. Additionally, it lowers the defibrillation threshold, making defibrillation more effective at lower energy settings. Lidocaine depresses the automaticity of Purkinje fibers, raising the stimulation threshold in the ventricular muscle fibers, which makes the ventricles less likely to fibrillate. After administering amiodarone or lidocaine, check for a shockable rhythm at the 2-minute mark. If one is present, return to step 5 and work through the sequence again until ROSC is achieved, at which point you'll move on to the post-cardiac arrest care algorithm. If you are unable to achieve ROSC in a reasonable amount of time, consider the appropriateness of continuing resuscitation efforts. non-shockable rhythms at step 4 or 6 and there are no signs of ROSC, go to step 10 or 11 on the asystole PEA pathway. The asystole PEA pathway is the option when the patient has a non-shockable rhythm after initial CPR. Give 1 milligram of epinephrine without interrupting CPR, repeated every 3 to 5 minutes, or every 4 minutes as mid-range, which corresponds to every other rhythm check. If the rhythm after step 10 is shockable, go to step 5 or 7. If the rhythm is non-shockable, continue CPR for 2 more minutes and attempt to treat reversible causes if these have been determined. If there are no signs of ROSC, repeat steps 10 and 11. If ROSC is established, move on to post-cardiac arrest care algorithm. The cardiac arrest circular algorithm is another way of displaying the cardiac arrest algorithm. It summarizes the recommended sequence of actions after a cardiac arrest. It makes the point that not only is high-quality CPR performed continuously, but also CPR quality is monitored consistently.
So, if we look on our algorithm, okay, so let's kind of go down, kind of each side of this and just kind of talk about it just a little bit more. So, basically our initial, so we get a patient, say we get a patient on the floor, we'll kind of go through this and then we'll kind of talk about it, make sure we go through, and then we'll run through a couple of scenarios and that with this. But so initially we go down to, room 10. We got a patient that we go in, we find him unresponsive. Same thing, BLS starts. We start call for help, start CPR. Okay, so right here we're kind of starting that top algorithm, right? Okay, so what's our next couple steps?
Positive or not?
yeah. Is it COVID positive? Room 10 it might be, but not today.
Is it a DNR?
Yeah, that's true. We gotta find out that. Okay, so our initial steps, we're gonna have some help. As soon as we get help there, start ventilating. So we're gonna give oxygen, attach a monitor. Okay, and then what's our decision point?
It's not really
A shockable rhythm or not, right? Okay, so we get them put on the monitor. It's VFib. So that's shockable rhythm. We're going to kind of go down the left-hand side of that. Okay, with VFib or VTAC, what's our initial, what do we want to do first with
early
that?
defibrillation.
Early defibrillation.
Yeah.
So as soon as we get that, the monitor down there and we get them hooked up, we want to deliver that shock, right?
CPR till it's charged.
Exactly. CPR till it's charged and ready, minimizing interruptions, shock, resume CPR. We don't stop, hesitate. CPR for 2 minutes. If they haven't got an IV or access at that point, we're trying to get an IV or an IO access at that point. 2 minutes, we're going to recheck again, okay? Is the rhythm shockable? That's still that decision point because they could change right there. So is it shockable? Yes, okay? Immediate, we're going to resume CPR again, charge, shock again. Okay, so then we're going to go down 2 minutes. This is where we're going to consider epinephrine. So it said in that video, the one thing they kind of point out is make sure you're giving your drugs while you're doing CPR. It doesn't really do you a whole lot of good to give a drug if you're not trying to circulate that. So give epinephrine during CPR. So at that point, we've shocked, we've resumed CPR. We're going to give our dose of epinephrine. Okay, and then 2 minutes again. Is it still, is it shockable rhythm? Analyze. If it is a shockable rhythm, give your shock. Go down again. 2 more minutes. We can consider if it stays in VTAC, pulseless VTAC, or VFib, we can consider an antiarrhythmic, either amiodarone or lidocaine. Kind of all along, they talk about treating reversible causes. It's like, okay, why is this happening? If it's an older adult, some common ones, are they acute coronary syndromes? Is it something like that caused the arrhythmia? Traumas, it could be, a number of those other things. We've had a couple patients the last little bit, like chronic alcoholism, horrible electrolyte imbalances, could it be something like that we need to correct? So we're trying to treat those causes, okay? So that's kind of going down that. We just keep going in that thing till the rhythm changes or something. So when we're at our 2 minutes and we analyze, and now all of a sudden we have asystole, okay? So that kind of takes us down. Is that a shockable rhythm?
No.
No, that takes us down that right-hand side of that pathway. So basically it says there's only a couple things we can do. High-quality CPR and epinephrine. So this one they talk about here on this, they've made it a little pretty clear. You want to give epinephrine right away. So we recognize asystole, it's not a shockable rhythm. We resume CPR, we're given epinephrine. Okay, so that's going to be our first line thing. That's really all we can do. It's not shockable. So if we don't have IV, you know, if we go check on this patient and we recognize, we get him on the monitor, we recognize asystole, and we don't have an IV, we've got to get that established because that's kind of going to be our law. Yep, exactly. Probably IO and a drill real quick. Yep. Perfusion sometimes at that point is pretty horrible. So, and then we're starting that 2-minute thing. Is the rhythm shockable? Nope, we're staying on that side. If it turns into a shockable rhythm, then we can switch to the other side. Okay, so this is all about cardiac arrest, pulseless rhythms. Okay, when we do our rhythm checks, we see an organized rhythm. What do we need to check for? A pulse. Okay, PEA can look like a lot of different things. If we have like an organized rhythm or some electrical activity, we got to check and make sure that they still don't have a pulse. Okay, and then that still puts us in that asystole PEA side of the algorithm. Okay, does everybody understand this one all right? Like I said, this is kind of the one you see probably the most, you know, with the code for sure. I mean, because that's where we're at, cardiac arrest.
Is there ever a situation where they try both amiodarone and lidocaine, or is it one or the other?
Usually one or the other. Usually they'll just try one or the other. We have both, like lidocaine, everybody had gone away when amiodarone kind of came out. Everybody was using amiodarone, and lidocaine kind of went by the wayside. But really over the years, as they've done the studies, there's really not a benefit one way or the other. It's just kind of, a lot of it's physician preference. If you have an older physician that's used lidocaine and that's what they're comfortable with, that's probably what they're going to use. You know, that's when I first started, we used lidocaine a lot. You know, but then now we've kind of got to amiodarone
and amiodarone's just a push.
An IV push. So.
And then the second dose is the bag that you hang, or is that one a push too?
You can do repeat. So let's look it up.
It's a 150 push.
Yeah.
It's a
For a
push.
cardiac
In a
arrest.
code
Versus
situation, it's a
3
push.
seconds, so 150.
So.
And then whatever they convert on, that's what the drip is.
Yeah, and that's like, yeah, if it happens to be the one they always said, if whatever medication you give them and they convert on, then that's the kind of the drip you're gonna hang to keep them, yeah, to hopefully keep them. So I'm gonna look on the drugs for epinephrine or amiodarone. So, cause we have the ones where you can do the drugs, but rapid, so first dose, 300 milligrams, and the second dose if needed at 150, and they're both rapid push. Okay.
You just have to be careful with it because it'll foam real easy.
Probably.
They used to have those in little boxes on those charts that they have the amiodarone out to the side on that. They used to have the little boxes out to the side.
It does in the book, but not.
It doesn't.
Okay. On the back. Okay.
So you don't have to give it over 2 minutes?
No, in a cardiac arrest. So basically think of it as if anybody has a pulse, then you're usually doing like drips, but if anybody doesn't, it's usually always rapid push.
So you want to shock the heart into doing something.
And then like the lidocaine.
The first dose is 1 to 1.5 milligrams per kg. And the second dose is a half to 0.75 mgs per kg.
And those doses, as far as like those, you won't need to know necessarily for the test, but
For real life.
just,
In real life, you can look at that card.
yep.
Yeah.
Okay.
Or the book. Does the amiodarone come in 300s? Or
Yes.
was it just
Yes.
the
There's
vial
like a-
for the second dose?
You know, too, with the lidocaine, we used to do that. If it was close to an amp, you just give the amp to make it quick and easy. So,
So let me turn, we'll kind of start, I'll give you a scenario, we'll just kind of go through real quick on here and give you. Let's see. Okay, so think about this. Let's just talk about this thing, and then we'll bring in, we'll go do some like a skill station. Bring it all together.
Right there, point at you guys.
Gonna plug it in.
Don't point it at me.
So EMS arrives in your emergency department with an unconscious man. The EMS providers are ventilating him with a bag mask device on arrival. The crew tells you that they were called by a passerby who found the patient lying unconscious on the street. So our initial vital signs from EMS, heart rate was 110, blood pressure is 100/75, respirations is 6 a minute, they're assisting him. SpO2 was 65%, temperature was 36.5 degrees Celsius, patient is 23, they don't know weight, okay? So here's the initial, as he gets there, the patient is unresponsive to voice and painful stimuli. The patient's pupils are pinpoint bilaterally, he has track marks on both arms and both feet. His respirations are infrequent and ineffective. He has snoring respirations with some upper airway obstruction. He has a thready pulse at approximately 110 per minute. So just on those basic things, like initially, what do we want to do?
Start
Ventilation.
ventilation.
Start ventilation.
Probably put in an OPA or an NPA to get rid of the snoring.
Okay, perfect.
And then I would just see if his SpO2 got or if his heart rate started changing.
IV access, hit him with some
IV
Narcan.
access. Okay, perfect. Yeah, starting noticing that. That'd be a good first thing to try for the respirations. If it's respiratory drive, it's only 6 a minute. That's decreased. Okay, so all right. Open the airway, place on a monitor, provide bag mask ventilation, IV access. Give a dose of Narcan, and we can repeat that dose again, right? Okay. Okay, so it says, despite the airway being opened, the patient's respirations remain slow, level of consciousness and oxygen saturations are unchanged. It progresses to apnea, and repeat pulse checks finds no pulse. Monitor shows an organized rhythm at 110 a minute. So we are now in
PEA.
Okay.
Start CPR.
So yeah, start CPR, good. If we hadn't got our IV or IO in, we gotta get that in, right? If we've got it in, what are we gonna do?
Epi.
Give epi, okay? We still, if we hadn't given our,
With a tube.
if we hadn't given our initial, like our Narcan, going down that, we gotta treat those reversible causes. So if we hadn't got our IV in and hadn't been able to get it, if we had nasal or whatever, we could do nasal Narcan, or we can try to give a dose of Narcan if we've got that IV, if
So
that's
with
what.
Narcan, how many times can you give it,
think
to up
it's-
to what dose maximum?
I'll have to look on that one to see total dose, but it says the ideal dose is not known, but 2 to 4 milligrams IV is usually reasonable
And-
as a dose.
And I would just say, if you give it, be prepared.
Cause when they wake
Oh,
up,
they
they
wake
wake
up.
up.
We had one guy, we
mad.
found out he was a Golden Gloves boxing champion, and we had somebody sitting on him, and he had extubated his tube and pulled out his IV.
Yep.
So, we didn't have a breathing problem after that, but, and we just had a, yeah, he was crazy.
We had that one in the ER, we gave a couple doses and it would work, you'd give it and you'd get a little bit of a response. And we ended up giving it a couple times, we ended up putting him
Putting him
on
on
a
a
Narcan drip to try to
Yeah.
keep it.
It doesn't last as
effective,
long as
yeah.
the actual,
So if
drug
it's gonna
overdose.
work, hopefully within a dose or two, you're gonna see that, at least some response. It may not last, like he said, but it, let's see. So we get that, okay. So this one just kinda ends on that as far as giving the, hopefully, if you get your IV, you give epi, that will change, but that's kinda where that one ends, a little bit on that. Okay, let me bring in, we'll kinda just do a couple more scenarios and do some skills, so.